Thank you. Well, it's great to be here and to be able to kick off this panel and talking about the pros and cons of efficacy randomized controlled trials. Any research design needs to be a match for the research question. And comparative effectiveness RCTs, the main aim of these is usually to compare the potential benefits and also the potential adverse effects of one intervention to another. An efficacy RCT is a specific type of RCT that is evaluating interventions under very carefully controlled circumstances. So the people enrolled in these studies tend to be highly selected. The interventions are delivered in a way that is probably going to ensure the ideal sort of outcome will occur. And this is in contrast to the pragmatic RCTs that John's going to be talking about next. If conducted properly, these types of trials provide a very high level of internal validity. So this means that these studies provide really the highest odds that we have of finding out if an intervention is truly superior to another intervention. What randomization allows us to achieve is an unbiased distribution of potential confounders. So confounders are those variables that are associated both with the treatment outcome and with the treatment intervention. And this can lead to confusion about what really is that association between the intervention and the outcome. What randomization does that really no other design can achieve is it distributes both the known confounders and those unknown ones, the ones we just haven't thought of or the ones that are just so difficult to capture and to measure. Now, a word of caution, randomization is not a miracle. It alone is no guarantee of a valid result. A poorly designed RCT, for example, a trial that lacks other elements such as blinding, intention to treat analysis, or one that is just so small that it's prone to random error, is not going to yield strong evidence and will lack internal validity. But randomization is the best approach that we have for dealing with this issue of confounding. And the reason I come back to this is that confounding is such an issue when we're trying to assess the relative efficacy of interventions. And this is because there often is a strong association between interventions and between the underlying clinical problems or functional problems that people have. We call this confounding by indication. And just to give one kind of basic example, it would be if somebody, say, had chronic headaches. An example of this would be someone with long-term chronic headaches is probably going to take more ibuprofen or other sorts of analgesics. If we were just observing those people, we might think that those medications were actually causing of the problem with the headaches. But in fact, it's the fact that they've got more severe underlying pain is the real problem there. That's what is confounding that relationship. It's another variable. But if we were just observing that, we might misinterpret that relationship because of the confounding. I wanted to just bring up what's probably one of the best known examples where observational data was inconsistent with randomized data, and that is looking at hormone replacement therapy to prevent cardiac events, MIs, in women. I think a lot of us can remember going back a decade or a few decades ago now that there were a large number of very well-conducted observational studies that found significant cardiac benefits. We're talking about like a 40 to 50% risk reduction in cardiac events for women who took hormone replacement therapy. And this was being widely promoted, not just by the pharma industry, but across the medical field for women to take this. Unfortunately, or perhaps, I guess fortunately, when the well-conducted efficacy RCTs were conducted, such as the Women's Health Initiative and other studies, they found absolutely no evidence of cardiac benefit. And in fact, they found evidence of strongly increased harm. Women were at much greater risk of breast cancer. Now, in hindsight, the assumption is that women who took HRT were healthier, had healthier behaviors in ways that reduced their cardiac risk, even though these studies tried very hard to adjust for these factors in these risk factors in their multivariate analysis. For example, they took things like smoking and other behaviors into account, but there were clearly unknown, unmeasured confounders that they did not pick up. This caused harm, this sort of mistake. It is now thought that the significant reduction in breast cancer cases that has occurred from 2002 until about 2005 is attributable to the decreased number of women taking HRT as a result of these trials. If we take it from that example back to thinking about disability and thinking about the potential for confounding when we're observing the relationships between interventions and outcomes, I can think as a physical therapist, for example, about when I'm designing an intervention program for somebody with spinal cord injury. I've got a range of interventions that I can choose for somebody that vary enormously in their challenge, their difficulty, their novelty. And the reason that I select these, there are a large number of reasons. I've listed some of them here. And these are potentially, these reasons that I select things are things that could all confound that association, where we might think that that new gizmo that we have is really what is causing somebody to have a better functional outcome. But it's in fact that it's the really motivated, determined people who we're selecting to give that to. There's some problems with this list that I've got here. The first is that it's a long list and that it's difficult to measure some of these things and time-consuming to measure these in this study. And the second is that there's no way I've got all of the confounders on this list. This is not an exhaustive list, and there definitely will be things that will be missed. And those could be important variables that if we were just observing, we would need to know to really understand if that intervention is making a difference to the outcome. I wanted to give an example of what I think is one of the strongest comparative effectiveness studies in the rehabilitation disability area, and that is looking at the issue of arthroscopy versus physical and medical therapy for knee OA. In 2006, there were about 1 million knee arthroscopy surgeries done in the US at a cost of about $5 billion. Now, not all of these were for OA, but a large proportion of them were. The efficacy of this was unclear. Observational studies had suggested benefit, but there was also one RCT that had been done that showed no benefit. However, there were legitimate methodological limitations, so this study was basically disregarded, as you can see by the fact that 1 million were done. Kirkley et al. Conducted an RCT exploring this issue. They included people with moderate to severe knee OA, and the two groups were arthroscopic surgery plus optimal PT and medical therapy versus optimal PT and medical therapy alone. The primary endpoint was the well-validated WOMAC score at 24 months out. 188 people were randomized, and the study was successful in that they had a relatively low number of dropouts and few crossovers in the treatment groups. However, when we look at the outcomes here, if we're looking at this if we're looking at the graph, you can see, I'm sorry.
Nancy, you can use the other pointer, Mike, if that's what you're looking
Okay, thank you. I'm just going to get back to the point. The graph is showing in red, which I'm just not even going to point at it. In red is the arthroscopic surgery group, in blue is the control group, and along you can see that it's graphing the WOMAC score versus the months since randomization. And the important point I was just trying to make visually is that at all of the follow-up endpoints along the different months from 3 months to 24 months, there was absolutely no evidence of benefit. So this is again probably an example where the people getting this intervention were who knows what, more motivated, more determined, had more money, who knows what. But there was something different about them that the observational studies hadn't picked up, that the randomization is now showing that this intervention, which is expensive, which is painful, which is invasive and potentially risky, really does not improve these outcomes at all. So randomization and efficacy RCTs are important, but I do not want to give the impression that I think that efficacy RCTs are the answer to every research question. Clearly, there are many research questions for which this is not the most appropriate design. For a few examples, treatments that require a very long period of intervention in order to see effects, or for determining very rare but potentially serious adverse effects. We also face, I think particularly in our field sometimes, ethical problems in that we've got a lot of interventions that have been widely adopted in practice without any evidence of efficacy. However, it is probably an ethical issue at this point when they're so widely used to randomize people to not receive those interventions. This presents a real challenge. There also is no need to do these interventions if the evidence of efficacy is so overwhelming. And I just like this BMJ article that I think tweak people like me who are maybe get overly earnest about RCTs, that a study to look at parachute use to prevent death and trauma, not necessary in this example. When we're thinking specifically about efficacy RCTs, in contrast to John's pragmatic trials, again, there are limitations of these in that the subjects are so highly selected, the treatment's so well controlled, that if we're trying to generalize this to the real patients in the real world, these very constrained studies have limitations in that generalizability. But I think the biggest barrier that people bring up for RCTs is the cost of them. The cost, the time, and the fact that they're fairly inefficient to do because we can usually only look at a few interventions at a time. But just before that leads us to the conclusion that we should not do efficacy RCTs, that other designs are necessary, I would just like to raise with this group the question of, is there some way that we can think of doing RCTs more cost effectively? It seems to me that the model for doing RCTs has barely evolved over decades. I think that most people in this room could attest to the fact that there are extremely high costs with each individual RCT in setting them up, in hiring and training the staff, in establishing the recruitment sites, in setting up the data management systems. A recent IRM report issued just a few months ago, actually, looked at this issue at clinical trials infrastructure and made a number of compelling recommendations that funders, industry, consumer groups, and other groups could do to potentially reduce, not to make them minimal costs, but reduce some of the costs of RCTs and increase the efficiency of them. And I think this is really worth thought and consideration. These studies are hard to do. Especially for disability-related CERs, we face challenges in that for these types of studies, we need to identify the right people and get them to agree to be randomized to one treatment group or another. They're needing to give up their autonomy for making that decision about their intervention if they adhere to it. And this is really challenging, especially if someone with a disability is either attracted to a new intervention or even more if they are used to a device, to a service, to a practice that they've been using for a long time. To ask them to be randomized to potentially to something different, that's a hard sell to get people into these studies. And it brings up a second but related problem, and that's when we're conducting comparative effectiveness research, there's a real problem of the potential of people to cross over from the assigned treatment group to the other treatment group. The SPORT trial, which was looking at surgery versus non-operative treatment for lumbar disc herniation, is a great example of this. This was an extremely well-designed and conducted efficacy RCT, but at 2-year follow-up, 40% of people in the surgery group did not actually have surgery, and 45% of people in the non-operative group had surgery. So it made it very difficult to determine the superiority of one treatment compared to another, and this is a really common problem. If people tend to be naturally biased to wanting one treatment more than another. It's a real issue, practical issue that we face in these studies. So just to summarize, I feel that we're at a really exciting point in time in disability and rehabilitation research. We have so much new technology that is emerging that I believe is going to increase treatment options and change the way we deliver care to people. But I also believe it's imperative that we evaluate the risks and the benefits of these approaches before they get widely adopted. Efficacy RCTs are clearly not ideal for every research question, but randomization is the only approach we truly have to balance the known and the unknown confounders, and we know that those confounders can influence the association that we see between the intervention and between the outcomes, and confuse the conclusions that we draw if we're just looking at observational data. Consumers with disability and clinicians need reliable evidence to guide complex treatment choices. The interventions that people with disability often get involved with involve a lot of their time and personal commitment. And if we're asking people to do these interventions that have no benefit, to me, that is causing harm. Before we reject RCTs, we have to accept that RCTs are expensive, and that is a limitation. But I think that an issue that we as a research group and people interested in disability research need to consider is what could potentially be done to evolve RCT design and the overall research environment that we're all operating in to perhaps make RCTs a feasible option for more disability-related research questions. Thank you.